Hello, everyone, and welcome back to class. So, this week we are going to be looking at some epidemiologic topics. This is part one of two lectures. Each one will last about 30 minutes. Before we get into this week's stuff, I've had a chance to review each of your posts for the Dirks et al. Article from last week. Really kind of an interesting topic here. Now, it looks like for some of you, your first exposure to frozen shoulder, or in this case, primary idiopathic adhesive capsulitis. That's to differentiate it from the frozen shoulder or shoulder stiffness that occurs after a post-surgical case. Now, very short article, interesting article, but you had some great critiques of it. And that's important. That's the most important thing, is that you are looking for the strengths and weaknesses, because that's the kind of stuff that's going to inform your discussion section of your scoping review or your systematic review. Being able to highlight those strengths of something and to show why that story that you're presenting is important for people for adopting into their practice, or within the weaknesses, within the limitations, you're discussing what is not known, why we maybe shouldn't adopt something into clinical practice, or to highlight differences between studies. Now, for some of the posts, I put a little bit more detailed or a little bit longer feedback, and often those were for individuals who had presented first. And then later on, some of you had some of the same critiques. And so I would say, see so and so, or see what I said earlier about this. That was just so that I wasn't repeating myself over and over again. A few common themes: people highlighting 77 patients, having a concern that that was a small number. Now, could that be a small number? Maybe, maybe not. One thing that the authors didn't tell us was if a sample size estimation was performed prior to conducting the study, to know if they had enough people to be confident that if there was something statistically significant found, that it wouldn't be an incorrect finding. 77 is a pretty large number, and I would err on the side of saying it probably would have been fine. But I also understand and take your point. Ultimately, if you don't know, if they don't report in the literature that they used something to do a power analysis, something to determine sample size prior to the start of the study, you have to make an assumption then that it could be on the lower end. Other concerns was that this was a publication going back 20 some years, going back to 2004, and everything that goes along with that. Has there been advances? Has there been advances in treatment, whether that has come from the primary provider side, like the orthopedic surgeon or the orthopedic provider, or from the physical therapy side? And from the physical therapy side, I would say that the answer is no. And the reason is that this is a tough study to conduct. To be able to say that you want to have people go one of two routes. If I was a physical therapist and wanting to do research in this area, I would need to have the support of an orthopedic team. I wouldn't just want to do this without their support, without their consent, because what if one group is not doing well, the other group is? How does that look like for my outcomes? If the orthopedic team's not involved, what are they thinking about what I'm doing as a professional? They might have concerns. Why is there such inconsistency? Do I want to keep referring people there if people aren't having good outcomes? So a study like this really needs to have involvement of the orthopedic team, and probably it's easiest if the orthopedic team collaborates with physical therapy, but the orthopedist leads it. Looking at some information from a physical therapy perspective, because there were questions regarding, well, what were the exact things that were occurring in the aggressive physical therapy group versus the neglect group? There wasn't great details. What you got an understanding from that was that the physical therapy group, they were getting aggressively stretched. They were getting mobilized. Manual therapy techniques were occurring, probably in conjunction with some exercises too. But what we saw the difference being that the neglect group were just told to stretch as tolerated. And then if you looked into the discussion, the doctors felt that this was due to this difference between groups was due to maybe the physical therapy group was being aggressively worked. It was contributing to the inflammatory cascade, thus delaying an individual's progression through the different stages of adhesive capsulitis. This slide presents summaries from a clinical practice guideline published by physical therapists in the Journal of Orthopedic and Sports Physical Therapy. That is the primary research journal of that organization. And look at joint mobilization and manipulation. So joint mobilization being what the manual therapy techniques would be performed by PTs. Translational manipulation under anesthesia. So looking at doing that manipulation, MUA. Both of those getting a C. Weak evidence, a single level 2 study or a preponderance of level 3 and level 4 studies, including statements of consensus by content experts that support this recommendation. And this is weak evidence. So it's saying you may utilize it, but it may work, it may not work. But what gets B? Stretching exercises. And stretching exercises determined by the patient's tissue irritability level. That gets a B. And patient education, understanding the natural course of the disease, activity modification, and stretching to the patient's current level of irritability. And a moderate evidence score of B, that equates to a single high-quality randomized controlled trial or a preponderance of level 2 studies that support the recommendation. So those concerns of it being an old study are warranted. You should always have concerns with that. But in some situations, as in this case, there is difficulty in doing these types of studies. There are studies that have been done in other countries that have looked at some different things. Those are usually a little bit weaker. You don't have a good sense as to when the individuals were diagnosed with adhesive capsulitis. So are they in the early stages? Are they in the later stages? So there's just some threats to the potential validity of those studies. This is going to be important for you when you do your scoping review or systematic reviews. If you're doing something that's drug-related, that turns over quickly, right? Something 5 years old is going to be probably too old. Something 10 years old may be, an eon ago. But for adhesive capsulitis, maybe 20 years of research would be valuable to explore. So it all depends, and you'll get an idea as you continue to do your literature reviews. You started that previously. You're getting a sense of that in the prior week as to what evidence is available on your topic. Okay, so getting back to this week, we're looking at different things that measure disease or injury frequency. And primarily, we're looking at prevalence and incidence in this lecture, in this part 1 of 2 lectures we're doing this week. Now, why is epidemiologic studies important? Well, one, you may be interested in looking at risk factors for something, you're going to do your scoping review on that. But probably for the majority of you, you're going to want to report in your introduction section the risk of developing something. What are the risk factors for it? And you're going to be interested in reporting rates. Your opening paragraph could say condition X is considered a common condition in older adults, 65 and older, with an incidence of 2 per 1,000 occurring each year. Risk factors for condition X include X, Y, and Z. So it helps to kind of set the stage for where you're going and illustrating why it's important to both evaluate and treat this particular condition, this condition X. Now, when looking at or when conducting epidemiologic research, you need to define the health state or the disease state of the population of interest. The World Health Organization, 1948, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. When doing epidemiologic studies, or when reading epidemiologic studies, you need to look at that definition of health and disease. What is it that people are reporting on? One thing I want to highlight here, you're going to see on these slides, it says Rocky Mountain University of Health Professions. There's a reason that is there. I teach a PhD level class in epidemiologic methods for that university each year. And these are some of the slides. Since I teach that epidemiologic class, these are some of the slides that I also present to those students who participate in that program. Now, some definitions in epidemiologic studies can be simple. Simple example being that the disease is absent or it is present. An epidemiologist or a researcher doing an epidemiologic study would then categorize subjects based on the presence or lack thereof a disease. And so of interest to us are prevalence and incidence. People oftentimes use these interchangeably. That is incorrect. Hopefully by the end of this lecture, you will have a good sense of the difference of the two. These help us to answer questions like what proportion of a group of people has a condition, and at what rate do new cases arise in a defined population as time passes. People who are susceptible to disease or injury are considered the population at risk. So when doing a study looking at injuries in high school athletes, you would not include college athletes, you would only include high school athletes. That makes sense, right? Other examples, you wouldn't include female subjects in a study involving the prostate. You most likely wouldn't include non-runners in a study looking at risk factors for running-related injuries. And you wouldn't include male subjects in a study looking at cervical cancer. Okay, there's two major classifications. There's a lot on this slide. We're going to break them down individually in a bit. There is prevalence and there is incidence. Under prevalence, they're going to have two types to explore, point prevalence and period prevalence. Under incidence, we're going to explore cumulative incidence and incidence density. Now, measures of frequency are expressed as proportions. In the numerator, that's the number of patients experiencing the event. Those are our cases. And in the denominator, that's the number of people in whom the event could have occurred. Prevalence and incidence data become useful to clinicians and researchers when it is converted to rates. So the number of cases and the number of corresponding people in the population at risk. And so you're going to see things reported as there were 10 per 1,000 or 10 per 1,000 athletic exposures. Point prevalence, this is a measure at a single point in time for each person. So let's kind of imagine point prevalence here. In this table, there are 10 patients. Overall, you're supervising a sample of 200 residents in a skilled nursing home. But 10 individuals have experienced a stroke, and that's what's being represented by the 10 patients up there. The dot represents when they first experienced the stroke. The continuation of the line illustrates that they have an impairment due to stroke. The X means that they have passed on, and the C means that they have been cured or there has been some improvement in their symptoms. So point prevalence, this is giving us information about a point in time. It's a cross section. So what would the point prevalence of residents impaired by stroke be in June of 2024 using this table? Take a moment here, do the math, pause the recording if you'd like. I'm going to go on now. The answer would be there were 7 people impaired with stroke out of 198. But wait a second, you said there were 200. Well, we have to take a look and account for the 2 people that passed away. So you're able to see that there, 2 people passed away. So then we're able to calculate 7 divided by 198 gives us 0.0354. And then we convert it to some factor of 10, that there were 3.54 residents out of 100 impaired by stroke in June of 2024. There's also period prevalence. And with period prevalence, this is kind of like an in-betweener between point prevalence and incidence. I know I haven't talked about incidence yet. You'll see what I mean in just a bit. What period prevalence does is it accounts for everybody who developed the condition over a period of time and all of the people who had the condition at the start of the surveillance period. So, for example, during a 1-year period of time, there were 20 pre-existing cases of meningitis and 15 new cases that developed in the population. So if the population was 30,000, we'd take 35 divided by 30,000, 0.00116, multiply it by some factor of 10, in this case 10,000, and we're able to determine that there were 11.67 cases per 10,000 people. Other prevalence measures that you might see within the research include lifetime prevalence, this being the total number of persons known to have had the disease for at least some part of their lives. I've seen, for example, lifetime prevalence of low back pain being 80%. I think you could look at things like, what is the lifetime prevalence of people developing a certain type of viral infection, right? They may not have it at one moment in time when you test them, but it illustrates how common or how frequent people get exposed to and how often they develop symptoms associated with that condition. Several factors determine prevalence, those being the severity of the illness, the duration of the illness, and the number of new cases. Take a moment to read through these. Basically, what this is saying is, if you're trying to, at one point in time, capture the prevalence of a condition within a population, it can be impacted by a number of factors. If the condition is severe, people may die before you get a chance to count them. If the condition is of short duration, the same thing. People may get better before you can count them. So take a moment. I'm going to give some dead air here for about 5 seconds. That's your point to Pause the recording and read through these. Make sure you understand these. Let me know if you have any questions. Go ahead and pause the recording now. Okay, I'm assuming that you had a chance to read through those. Let's continue on. Prevalence studies can be influenced by many factors unrelated to the cause of the disease. Thus, prevalence studies do not provide strong evidence of causality. Prevalence studies are helpful in assessing the need for preventative action or planning health services. So, for example, a sports medicine situation here, the prevalence of patellar tendinopathy in male basketball players ranges from 30 to 55%. If you're not familiar with this, patellar tendinopathy, this is a state of kind of a failed healing response in response to repeated sport activity. So patellar tendinopathy appears to impact individuals who do lots of jumping activities like basketball players and volleyball athletes. It's more common in those groups. So what happens is people develop pain in the patella tendon. It appears to be a common problem. It can be a persistent problem. It may not cause time loss from sport, but it may impact performance. And for some individuals, they may retire prematurely from sport because they have difficulty recovering or having alleviation of symptoms when playing that sport. We did a study here at George Fox University, and we invited not only the George Fox basketball players, but basketball players from 6 or 7 other collegiate teams in the Portland, Oregon region. And we put them through a series of tests, and also we had them get evaluated with diagnostic ultrasound. So as they came in, prior to doing other tests, we used diagnostic ultrasound to evaluate the health of their tendon. We also palpated the patella tendon. So we were determining tendinopathy based upon pain and the presence of tendon abnormality. And we were also looking at asymptomatic tendon abnormality. What determines tendon abnormality? Well, you can see in that image there the outline of the borders of the patella tendon coming off of the patella. And what we're seeing there are these blackened regions. These are the hypoechoic regions that are suggestive of a failure of inadequate collagen turnover or remodeling of the tendon itself. So people can have these hypoechoic regions and not have pain, or they can have pain and also those hypoechoic regions. What we found, most people, 55.8%, did not present with pain during palpation or ultrasonographic evidence of patellar tendon abnormality. But some people had ultrasonographic evidence of patellar tendon abnormality, and some people had both pain and abnormality. So 1 in 3 male collegiate basketball players at the start of the season presented with either patellar tendinopathy or patellar tendon abnormality. And we also calculated the prevalence odds ratios. So what are the odds that one group versus the other had a greater presentation of patellar tendinopathy or patellar tendon abnormality? One characteristic was significant. Non-starters had a greater odds of having patellar tendinopathy or patellar tendon abnormality. That really is kind of interesting. You might think starters playing more, but really everybody plays about the same because they're all practicing. Starters are the ones that get to play more in the game. Is that enough to make a difference? Well, it doesn't appear to be. So the non-starters, or these individuals that maybe have a greater genetic predisposition to developing patellar tendinopathy or having a tendon abnormality, and maybe they don't perform as well because they're playing in pain. I don't know. See, we can't say for sure. We're just saying that there is a greater odds here. Incidence is the fraction or proportion of a group of people initially free of the outcome of interest that develops the condition over a given time period. Incidence then is the new cases of disease occurring in a population initially free of the disease or of the outcomes of interest. So you can see how I made that comparison of period prevalence being everybody that has it at the initial point in time, and then everybody that develops it over a period of time. Incidence is basically now we're only counting those people who are injury-free or disease-free or don't have the outcome of interest at baseline. Incidence is calculated by the number of new events in a specified period divided by the number of persons exposed to risk during this period. Cumulative incidence is the number of new cases of a disease during a given period of time divided by the total population at risk. So in this example here, we have 5 runners, and we're looking at what is the cumulative incidence of patellofemoral pain syndrome among high school runners. And you see that 2 people developed patellofemoral pain syndrome, and so the cumulative incidence is 2 divided by 5, or 40%. So it's 40 per 100 runners. Incidence density is now taking a more, well, let me just read it to you here. It's a more precise measurement than cumulative incidence. It's the number of new cases of a disease during a given period of time divided by the total person time of observation. So what we see now, so what do we see that's different here? We see a total time at risk. And so this is accounting for the potential exposures, gives us a more precise incidence. So now what we would do is we would calculate the total time at risk, and we would divide the number of people who experienced it, 2 cases, divided by 16.5 person years, and then make it by some factor of 10 to inform us that 12.1 per 100 person years of observation occurred in this case. So 12.1 developed patellofemoral pain syndrome per every 100 person years of participation versus 40 per 100 runners. Quite a different data set, isn't it? Or a different risk magnitude. There's some commonly used rates like case fatality rate, complication rate, infant mortality rate, and so forth. Please take a moment to pause the recording, and I'll give some dead air. Then you can start back up again in about 5 seconds. Here we go. Okay, continuing on here. Designing a prevalence study. These are typically cross-sectional studies, meaning we're collecting at some point in time, whether it's all at one time or within a similar time period. So for example, when I've done my sports-related epidemiologic studies, I'm not collecting 7 teams of data on the same day, but in a relatively early time period in that preseason. Advantages of these studies: they're good for describing prevalence and examining some associations. They're fast and relatively cheap to do. You don't have dropout as a problem. Serial cross-sectional studies can provide trends and the first step in more rigorous study. There are limitations to these studies in that they cannot infer causality, and they're not good for rare diseases or those of brief duration. Here's an example of serial cross-sectional studies. If you just did it at one point in time, that'd be a point prevalence for the year of 1990. Maybe that's reported. Here is a study example, 5% of Major League Baseball players using steroids. But you could do overtime to look for trends. And we see these repeated measures, 15% in 1995, 30% in 2000. These studies, again, important for planning health services. They provide valuable information about what to expect in different clinical situations, and they're less time-consuming. They're relatively inexpensive, but they're only weak evidence for cause and effect. In an incidence study, the population that's assessed is the cohort, hence the term cohort studies. They may also be called that. The cohort is a group of people that have something in common when first assembled, and they're followed over time for the development of outcome events. So, for example, I've worked a lot with Division III athletes, and so my cohorts are Division III athletes at the start of the season who are injury-free. Other examples, you could have a study looking at individuals who are cancer-free and observe them over time until the onset of cancer. Or you could have a study where all individuals may have been diagnosed with the disease, and then you're following them forward in time for outcomes like recurrence or death. Now, I know I said with the incidence studies, they're primarily disease-free or outcome-free at the beginning, but you could also do it like that where you're looking for rates of recurrence. So maybe these are people that had the disease and they were treated, and now you're looking to see about that recurrence of it. Have you heard about the Framingham Heart Study? Probably have. If you haven't, this goes back many generations. It's quite impressive where they followed people over years and years to come up with potential risk factors for heart disease. Now, you can imagine with the Framingham study, I alone could not do something like that. I alone could not follow 15,000+ participants by myself maintaining that data. So they're challenging. You have to follow large populations for long periods of time. Thus, you need money. You need resources. They're expensive. They may not be good for rare diseases. So what if you are following a population of 50,000, but the incidence is 1 in 100,000? You could follow a large population and not capture any people who develop the disease. Loss to follow-up can introduce bias, but what are the strengths? You are able to appreciate the temporal sequence. Did the exposure precede the outcome? So these are considered the best for epidemiologic purposes. You're able to calculate incidence rates, and you're able to study rare exposures. All right, we're all done. Let's head over to lecture 2.